Okay. Good afternoon or good morning or good evening, everyone. Glad actually to be back after a while. It's already 1:05, so I guess we can start before delaying things further than this. It's good to see you all back. As you know, this will be recorded, so I hope no one minds that. If you have any questions, please note them down. For the sake of time, by the end, inshallah, we will be answering all of them. And even if you want to discuss anything related to the matter, I have no problem. I'm free after this presentation. So this presentation was made, if you remember, I sent you a survey on the WhatsApp group. What are the topics that you are interested in? This was one of them. And it will be one in a series of similar presentations because I know there are a lot of information that it will not be just easy to go and read through every document, and my documents are quite long. So you can say that this is a summarized version of many important details related to routine tests that you'll not easily find in IFUs or user manuals or anything like that. Anyways, Bismillah. This presentation is mainly focused on PT, PTT, fibrinogen, and D-dimer. Now, see, I'm not trying to take you back to coagulation school here or anything, but these are stuff which are very important to sales and to application alike, because these are things which can help you really solve basic problems that the users may face, but may not realize that these problems exist. They will think, oh, it's a problem with your machine. Oh, it's a problem with your reagents. Where is the engineer? Why is it like that? Even though the solution is very simple. So anyways, let's start with the topics. The topics will be, first of all, we will talk about PT, PTT, and fibrinogen. Why do we run them? Now, this might sound very basic, but again, I promise you there will be things which are very interesting. Then, PT, PTT, fibrinogen, they have problems. You have abnormal results. What do you do next? What is the workflow after this point? Then, after we have checked the abnormal results, we have an indications that maybe it's a vector deficiency or it's an inhibitor. Some details about that are quite important in your day-to-day work, so we need to cover that. Finally, we'll talk about D-dimer. There are a lot of queries that come about D-dimer, and again, on the user side, it might look like there's a problem, there's a discrepancy, it doesn't make sense, something is wrong, but actually it's something that is completely normal, but this information is really important for you to know. Again, all of these can be also very important to sales, because the customer might tell you, no, your product has a problem. Why would I use it? I will use the competitor. It's cheaper. It's this, it's that. So this is really important. All right. Now, first of all, PT, PTT, fibrinogen. Why do we run these tests? Now, first of all, as you know, PT, PTT, fibrinogen, they are you can say, I hope these notes are not showing on the side. Just give me a second. No, we are good. Okay. So PT, PTT, fibrinogen, as you know, we run them to make sure that the patient's coagulation cascade is more or less okay. There is no problems. We all understand this bit. Patient wants to go to surgery. We need to check that. Patient maybe has some bleeding problem. We need to check that because it gives us a very general idea about the coagulation. That's fine. So we are screening for the quantity of coagulation factors, the function of coagulation factors. We all understand this bit. Now, one very important note that some people might not realize is that PT, PTT, fibrinogen, you might hear that there are inhibitors that cause a prolongation of PT, PTT, or might interfere with fibrinogen. But when we talk about these inhibitors do not refer to your normal coagulation inhibitors. Because for your body to function normally, you need coagulation inhibitors. We cannot let coagulation start without a way to stop it. So PT, PTT, and fibrinogen, they cannot give you any idea about your natural coagulation inhibitors. One of them, for example, is a protein C. Another example is a protein S or antithrombin. So these are natural coagulation inhibitors, but they have absolutely no effect on PT, PTT, and fibrinogen. They are very different from acquired inhibitors. something that is like heparin, something like lupus. These are not something that is naturally present in your body. We will come to this bit. Now, okay, when PT, PTT, and fibrinogen are normal, we can say you are normal, fine, we can go with the surgery, everything is okay for you. However, when PT or APTT are abnormal, now this does not indicate any specific problem because so many things, as you can see in this graph to the right or this list to the right, so many things can cause a prolongation on in PT and APTT. But when PT is prolonged or APTT is prolonged, you can never pinpoint the exact problem. You need to investigate further. So PT and APTT are just meant for screening. If they are normal, that's good. You're okay. If they're abnormal, we really don't know what's going on. So that's what I mean with not specific. When they are prolonged, we cannot really pinpoint a single issue. Now, how about fibrinogen? Now, many people would think, okay, PT and APTT, when they go through the extrinsic, intrinsic common pathway, that's all fine. If there's a problem with fibrinogen, I should know through my PT, APTT. Why do doctors request this fibrinogen? What's the point? Why should I pay more? Why the waste of money? Why the waste of effort? Now, please keep in mind, PT and APTT are not sensitive to small deficiencies in fibrinogen. Let's say, for example, your fibrinogen range is 2 to 4 grams per liter. If your fibrinogen is maybe 1.7, 1.8 grams per liter, PTT and APTT will very likely be completely normal. So urine PT, PTT for a patient with slight deficiency of fibrinogen, patient will look normal, even though that might be significant for some patients if their fibrinogen is slightly low. So when the doctor requests fibrinogen, it's because that doctor probably knows that PT and APTT are not very sensitive to fibrinogen deficiencies. Yes, if it's a very severe fibrinogen deficiency, PT, APTT will be prolonged. But again, if it's a mild deficiency, PT, APTT are not sensitive to these kinds of deficiency. However, your fibrinogen assay is very good at detecting these deficiencies. Now, by the way, you might notice some slides as we go forward. It says check notes on the lower left corner of the slide. These slides will have notes at the bottom of the slide itself. So you can open it, you will see some extra details. They are just too much details. I did not want to include them in the slide. That will give you further details about what I'm explaining in this particular slide. So if you want to go through, read through that, that will be very informative. So any slide with check notes in the lower left corner, you'll have some extra details. I would suggest you go through that. It will be very good. Now, about each test individually, there are some important details that you need to know. For example, PT. Why are you telling us about PT? You already know everything about PT. Yes, but there are some important points which are not normally discussed. Now, first of all, if you have noticed, when we run factor assays for extrinsic and common pathways, we use PT. Why don't we use APTT? What's the point? Now, PT as a reagent or PT as a test, to be more accurate, PT as a test, it's more sensitive to factors in the extrinsic and common pathway. APTT is sensitive for coagulation factors in the intrinsic pathway, of course, by definition. APTT is sensitive also to factors in the common pathway, but it's less sensitive than PT. That's why PT is preferred to APTT when I'm trying to quantify factors in the common pathway. Why? It gets very complicated. There is no need to explain that, but you should know that PT is more sensitive to common pathway factors than APTT is. So, for example, APTT might be normal for someone with a mild factor deficiency of factor 10. However, PT will very likely be prolonged because PT is more sensitive to common pathway factors. Now, the other thing which is very important, which many people may not realize, PT reagent has a heparin inhibitor. So even if your patient has heparin, particularly unfractionated heparin, PT is not sensitive to that up to a certain limit. So for example, for unfractionated heparin, if unfractionated heparin in the patient blood is higher than 1 IU per ml, then PT will be affected. But 1 IU per ml for unfractionated heparin is way too high. It's very unlikely you will encounter that. Now, this heparin inhibitor is called polybrin. It's the name of the compound. Now, the point is, you might ask, why do I even need a heparin inhibitor? If the patient has heparin, I would like to know. Now, keep in mind, PT is primarily used for screening and for warfarin monitoring, vitamin K antagonist monitoring. When you do warfarin monitoring, I don't want heparin to be an interfering source because some patients, when you start giving them warfarin, you have to give them heparin at the same time. But if heparin has an effect on PT, then you will not be able to monitor the effect of warfarin at the same time. So we really need heparin inhibitors. Okay. We really need heparin inhibitors for PT reagents because otherwise we cannot really quantify the effect of warfarin on patients when they start taking INR. Just for your info, heparin is given for a few days when you start warfarin for some people, and then it's stopped. In this very critical stage, if heparin is an interfering source, big problem for me. I cannot monitor the effect of warfarin on the patient. Now, another important point. PT reagents usually have very high levels of phospholipids. Why is that important? Any reagent with very high levels of phospholipids is not sensitive to lupus. When it comes to PT, I don't care about lupus. All right? Usually APTT is the standard assay for screening for lupus. PT has normally very high levels of phospholipids. It has to do with the way it's extracted, etc., etc. Not our topic. But PT generally is very insensitive to lupus. So the customer might say, okay, the patient has lupus. Why is your PT normal? Because PT has very high levels of phospholipids. That's why PT is a very bad test to screen for your lupus. It's very, very insensitive to lupus. Now, one point that so your customers might not realize, when using INR, when it was created, when it was validated, when it was studied, it was only validated and studied for patients who are taking vitamin K antagonists, most famously warfarin. This means, for example, a pathologist will ask you, okay, can I use INR to monitor patients who have liver disease? Liver disease, where the coagulation factors are produced, can affect the levels of coagulation factors. However, using INR for any purpose other than monitoring patients on warfarin will give you bad results. It's not clinically validated for anything except for patients who are taking warfarin. So you have to be very careful with this point. Okay, what are the references that say that? First, CLSI. It tells you clearly INR is only validated for patients who are taking vitamin K antagonists. Again, most famous example is warfarin. Now, one of the most common issues that I get basically. The lab will be, okay, your INR is very different from Siemens INR. It differs quite significantly from IL INR, especially at higher values. What's going on? Now, keep in mind, most competitors, they give the customers recombinant PT reagents. Recombinant meaning the activator and the PT reagent, the tissue factor, is produced by recombinant methods. Our PT reagent, neoptimal, is not produced by recombinant. It's extracted from rabbit brains, etc., etc., etc. Now, this difference in the way the PT reagent is made can have a significant effect on INR. Now, this difference in INR, this discrepancy in INR between the reagents, between, let's say, neoptimal and I keep forgetting the name of that reagent from Siemens. I think it's Thromborel. Anyways, PT reagent generally from competitors are recombinant because they tend to be more stable on board, etc., 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 but they have their problems. So if the customer comes and says, your results are very different from Siemens, the results are very different from IL, okay, what are the reagents you're comparing? Are you comparing Neoptimal, which is a rabbit brain extract, to Siemens, which is a recombinant reagent? If that is the case, that's not really a very appropriate comparison, especially when INR starts to go above 2 or 3. And there's a lot of evidence that supports that once your INR starts to go above 2 and 3, the discrepancies in INR between recombinant reagents and rabbit brain, or we call them extract PT reagents, you will start to see differences. So please keep that in mind. If the customer comes to you with this query, please check what is the PT reagent that you are comparing. Are you comparing rabbit brain extract to rabbit brain extract? Or are you comparing recombinant to rabbit brain extract, for example, where discrepancies are expected to arise? If that is the case, there's a lot of evidence again to support that this is not a very appropriate comparison. Now, a few points about APTT. APTT is a headache, honestly, as I'm sure all of you have experience. Now, what is the main point of using APTT? Again, just like PT and fibrinogen, we are screening for problems with coagulation factor deficiencies, mainly the intrinsic pathway. Common pathway, we see PT is more sensitive, but APTT is still affected. Anyways, so apart from screening patients for a pre-surgery, where the main concern is coagulation factor deficiencies, I can use APTT to monitor lupus or to screen for lupus, as you know. I can use APTT to monitor or quantify unfractionated heparin. That is why APTT has no heparin inhibitor, because we know that customers still use APTT to quantify the levels of unfractionated heparin. So if we put a heparin inhibitor, the customer can no longer quantify heparin. So, you have basically removed one of the main uses of APTT for many customers. Again, that's why we don't have a heparin inhibitor in the APTT reagents, because we know some customers still use it to monitor heparin. Now, one very critical point that you will keep hearing over and over and over again. My APTT is very different from Sysmic's APTT. Why is your APTT saying this patient is abnormal? That PTT says this patient is normal. Why is your PTT automate saying this patient is abnormal, while CKPress says this patient is normal? What's going on? This is discrepancy. Take your machine out. Anyways, the idea is APTT reagents can be quite different in their results. And the primary reason behind that is the composition of the reagent is different from reagent to reagent. Even, for example, PTT Automate and CKPrest. They are both from Stago, but their composition is different. Why would Stago make reagents with different compositions? Because we need different APTT reagents for different uses. Not all APTT reagents can do everything that you want. Actually, you will see in some slides ahead, there is no such a thing as an APTT reagent that can do everything that the lab needs. Lab needs, depending on the patient, can be quite different. So we have to make reagents with different compositions, and that actually leads to different sensitivities. So for example, some reagents will be sensitive to lupus, some reagents will be sensitive to heparin, some reagents will not be sensitive to heparin, etc., etc., etc. I will detail a little more over this point. Now, again, as mentioned, there is no such a thing as a universal APTT reagent. Even if the customer says, no, we had this reagent from the competitor, it was perfect, it was fine. And a lot of cases when they say this reagent is perfect, this means it was not out of the limit as much, so it was comfortable for them. They did not have to investigate things. But this means maybe they are using the wrong reagent for the purpose they want. If you want to use a reagent for screening for lupus, for heparin, for factors, you need a reagent that's sensitive for all of them. If you want only to screen for factors, you don't want a reagent that's sensitive to heparin. You don't want a reagent that's sensitive to lupus. So depending on the lab use, okay, we need to have reagents with different sensitivities. Otherwise, simply you as a lab are using the wrong reagent. So how do I discuss this point with the lab? You can simply ask the lab, what are your main points of interest when running the APTT? Is it just a pre-surgery screening? Because a pre-surgery screening, I'm only concerned with factors levels. I don't care about heparin and lupus. The customer says, yes, I just care about factors levels, pre-surgery screening. You give them CKPrest, for example, because CKPrest is poorly sensitive to heparin, poorly sensitive to lupus, which are in this case interfering sources. I don't care about presence of heparin. I don't care about presence of lupus when I'm doing pre-surgery screening. If the customer says, no, if there's heparin, I want to know. If there's lupus, I want to know. You give them PTT Automate, for example, because it's sensitive to all of this stuff. So as you can see, different regions will serve different purposes for the customer. And this is a very critical point, because if you give a customer who cares about pre-surgery screening PTT Automate, they will come to you and they will not be happy. They will keep telling you, your reagent keeps going out of limits. My patient is normal. Patient might not be normal, but in terms of pre-surgery screening, the patient is normal. There is nothing to stop the surgery. And if your APTT is prolonged, they will stop the surgery. So it's a very major inconvenience for them. So this point is very important. Now, this point is even further complicated when you compare methodology to methodology or analyzer to analyzer. Okay, but the main source of variation in APTT, it is the reagent itself, much more than the analyzer. So briefly, when it comes to sensitivity to factors levels, when I talk about sensitivity to factor levels, I mean, when does my reagent give me a prolonged results or a result out of the reference range? This is what I mean with sensitivity to a factor. So if, for example, reagent X becomes prolonged when the factor level is 60% or below, another reagent gives me a prolonged result when the factor level is 40% or below. The first reagent is more sensitive because it can detect factor deficiencies at 60% or below. Okay, so this is what I mean with sensitivity. Some reagents will detect a smaller drop in factor level as compared to another reagent. That's why you might have a very normal patient. They just have a slight factor deficiency. One reagent says, oh, prolonged. The other reagent says, no, it's normal. This is one of the factors. Okay, what else? We have sensitivity to heparin. Again, if you remember, I said, for example, CK-Prest is less sensitive to heparin than PTT Automate. So in this case, the same patient might give you two very different results between PTT Automate and CK-Prest, let alone if you compare other reagents from other manufacturers, which will have very different results. As you can see, for example, these are all different reagents in the left column, highlighted in red. And you will see that the values are very different. This is the table of values. The values are very, very different when the patient is taking heparin between these reagents. So you can see these are the average ratios for patients taking heparin. And you can see the differences are huge between these reagents, which tells you that the sensitivity to heparin is quite different, which will again create another cause of discrepancy. But we understand that this discrepancy is caused by different formulations of reagents. All right, the last one is sensitivity to lupus. Now, again, depending on the phospholipid content of the reagent, the sensitivity of the reagent to lupus will be quite significantly different. And this is even another cause of variation between reagents. So for example, CK-Prest is poorly sensitive to lupus because it has a very high concentration of phospholipids. PTT Automate is very sensitive to lupus because it has a low concentration of phospholipids. Now, one very important note. The way lupus works is that it binds the phospholipids in the reagent. So the higher the phospholipids, the less sensitive the reagent is to lupus. We will not go into the mechanism of that. But CRP, C-reactive protein, it behaves in a very similar way to lupus. So some people who have a very high level of CRP, who have, for example, severe inflammation, they have severe infections, their CRP shoots up because CRP goes high with inflammation. Now, CRP again behaves very similar to lupus, so it can and it does cause a prolongation in APTT. So if the customer says to you, for example, this patient just has a throat infection, why is your PTT automated prolonged? Okay, the patient has an infection, the CRP will be high. High CRP can actually interfere with PTT automate. So now the customer will understand that, oh, there is actually a valid reason for a prolongation. But then they might tell you, okay, why is your CK-Prest not prolonged? Because again, CK-Prest has a high level of phospholipids. CRPs function in a similar way to lupus, meaning that it binds phospholipids. The higher the phospholipids, the less sensitive the reagent to lupus or to CRP. So CK-Prest is poorly sensitive to CRP. Now, if you look to the right side, I mentioned that some medications also function similar to lupus. Actually, some people who take some medications, such as antipsychotics and some antidepressants and some antibiotics, actually, their results for APTT, it will look as if the patient has lupus. So it's very important to know these details. So sometimes, even if you ask what the medication is the patient taking, you would know that this medication can actually cause a prolongation in the results of APTT, especially for PTT Automate. That is why I told you in the beginning, it's very critical to understand the customer need behind running the APTT. Do you want your reagent really to be sensitive to all these things? Do you want to screen for any abnormalities in the patient's blood? PTT Automate is your answer. If you just care about pre-surgery screening, all I care about with the pre-surgery screening is factor deficiency. I don't care about anything else. So I don't want anything else to cause unnecessary prolongation in my APTT because otherwise I will stop the surgery, even though this thing that causes prolongation has nothing to do with surgery. So it's very critical to understand these points. Now, just to give you a small demonstration, these are two actual manufacturers. I think these are Siemens, Sysmex, and IL. As you can see, sensitivity to lupus, sensitivity to factors, sensitivity to unfractionated heparin. As you can see, reagent 1, reagent 2, reagent 3, reagent 4, these are all reagents from the same manufacturer with different levels of sensitivities to lupus, to factors, to unfractionated heparin. So it tells you that there is no reagent like the other, even within the same manufacturer, in terms of its sensitivity to these things, the lupus factors and unfractionated heparin. So if the customer comes to you and says, no, 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 Sysmex reagent is perfect, it does everything perfectly. What do you mean with perfectly? Do you mean in terms of procedure screening? Do you mean in terms of screening for lupus and for heparin? Because no one reagent can do all of that at the same time. You cannot possibly be sensitive to heparin and insensitive to heparin at the same time. You cannot be sensitive to lupus and insensitive to lupus at the same time. It's simply impossible. So this is just to demonstrate these differences between reagents. And again, for APTT results, the biggest contributor for values is the reagent composition itself, much more than the methodology. Now, to further reinforce this point, and if you want evidence to present to the customer, they say, oh, we want a letter from Stago. Fine, that's available actually. We have a document that's called APTT Inter-Assay Variability Information Letter. Actually, it's written by the Clinical Development Director in Stago, Dr. Francois Depasse. He's actually even a member of ISTH and member of CLSI. So you can say that it's a very good letter to present to the customer. So if they say anything, yeah, but we want supporting evidence, this is available. Actually, the internet is full of articles to support the same. So you will not have any problems in that department. If you wish to have that letter, please let me know. I'll send it to you. Now, moving on to fibrinogen. Fibrinogen is not as clear-cut as PT and PTT in terms of why do I run fibrinogen? So many things actually cause increases in fibrinogen and decreases in fibrinogen. We will come to those. But before we go to that point, a bit about the test itself. You might have heard from some of your customers that, okay, but IL, for example, is giving us a reagent that is PT, but at the same time gives me fibrinogen. We call that PT-derived fibrinogen. So actually what happens, it's actually a PT reagent, but the analyzer will also provide you with a fibrinogen result based on the PT clotting time. How? We don't care about the how at the moment, but it actually is a PT reagent that does actually give you a fibrinogen result. So you probably say, oh, this is wonderful. How can we compete with that? Now, okay, obviously this will come at a huge cost saving for the customer. But you have to pay attention to a very important point. PT-derived fibrinogen is not the standard for fibrinogen. The gold standard for fibrinogen is a methodology called the Klaus method. Klaus method is the one we use, the liquid fib reagent, or actually all competitors really have it. But the Klaus method is, I dilute my plasma, I add a thrombin reagent. By the way, the liquid fib reagent is just thrombin, okay? So I dilute my plasma, I add a thrombin to it, then based on the clotting time, I know the concentration of fibrinogen. This is the Klaus method. I don't use the PT reagent. Klaus method is the gold standard for fibrinogen measurement. Now, Stago does not offer PT-derived fibrinogen. There are reasons behind that. They are out of the scope of this presentation. We use a Klaus method, the gold standard. Okay, then what are the problems with PT-derived fibrinogen? How do I answer to the customer in this case? Now, PT-derived fibrinogen is only accurate within the normal range of results. So if your PT-derived fibrinogen is saying your patient is normal, they are between 2 to 4 grams per liter, fine, the results are okay and acceptable. But the moment the results of fibrinogen are out of range, higher or lower than the range, the results of PT-derived fibrinogen are no longer accurate. In this case, you must run the Klaus method to get an accurate fibrinogen result. Otherwise, you cannot rely on the PT-derived fibrinogen. That's the first problem with PT-derived fibrinogen. Yes, it's cheaper, but then you will end up running Klaus method. So the stability of the reagent, okay, on board, okay, I will have to put the fibrinogen reagent, I will have to put the PT reagent, but I am not using the fibrinogen reagent all the time. I will end up wasting the vial because it cannot stay on board forever. So you ended up using the fibrinogen reagent no matter what. The other problem with PT-derived fibrinogen. Now, as you know, if your patient is taking warfarin or your patient has any issue that can interfere with PT, your PT-derived fibrinogen value is no longer valid. Because if you have anything interfering with your PT, okay, the interference is with PT. How can I know an accurate value of fibrinogen? Maybe my fibrinogen is completely fine, but the PT result is not fine. So my fibrinogen looks like it's not fine, even though your fibrinogen is actually fine. The problem is with the PT test itself. So an interference is with the PT, which you might not realize exists in this patient, will interfere with your fibrinogen results. So that's another problem with PT-derived fibrinogen, is that any interference with PT, even if the patient is just taking warfarin, your fibrinogen result is not accurate anymore. You will have to end up using the class method. So you cannot just stop using the normal fibrinogen test if you have PT-derived fibrinogen. You cannot. You must have it. So pretty much the cost will end up being the same, plus the extra headache because you have to reflex now to running fibrinogen. So you will end up doing the same. Not to mention that you might miss some patients which actually have normal fibrinogen, but you classify them as having a problem with fibrinogen because there is interference with PT. Now, fibrinogen is made in the liver as many coagulation factors, so any problem with the liver will really cause an increase or a decrease in fibrinogen. Many of the problems listed here will actually also cause problems with fibrinogen, which means that fibrinogen is requested for so many reasons. So for example, if the patient had a bleeding, I give them a transfusion, I might need to use fibrinogen to monitor for how did their fibrinogen go up, did it go down, did it do this, did it do that. I can use it also to monitor DIC, disseminated intravascular coagulation. If they have a problem with their liver, I need to monitor that. Also, fibrinogen can help me, etc., etc. So fibrinogen is requested for many reasons. One of them is a pre-surgery screening, because if your fibrinogen is low, you cannot really go into a surgery. You might bleed. But there are many other reasons where I request fibrinogen. However, sometimes the quantity of fibrinogen can be normal, but fibrinogen itself may have a mutation. The structure of fibrinogen is damaged, for example. Okay, we say that quantity is normal, but the activity is abnormal. Its function is abnormal. Now, if the function of fibrinogen is abnormal, you will still get low readings. Actually, it's in your body, it's a normal level, but because it cannot function well, the clotting time is not normal, which means that you will get an abnormal reading. Now, this kind of deficiencies, this kind of mutations, this kind of qualitative problems of fibrinogen are more difficult to diagnose for obvious reasons, because you might think, okay, it's just a quantitative problem, but then later on, you may or may not realize that actually it's a problem with the structure of fibrinogen. Now, this kind of issues with fibrinogen, mutations can actually cause bleeding, or can even in some cases cause thrombosis, or you might be completely normal. You might ask me, but how come a patient has a problem with fibrinogen and they have thrombosis? That does not make sense. If you have a problem with fibrinogen, you must bleed. But actually, up to 25% of people who have mutations with fibrinogen actually end up having thrombosis. We will not discuss the mechanism, but actually that's true. Now, fine, we discussed the basics, we discussed the routine, that's okay. If anyone has a question, you can ask before we continue with the next points, because it's very important for me that you understand the basics. Any questions about what we have discussed so far? If you have, please let me know, so we'll continue with the rest. All right, then I assume there are no questions. All right. If you want, we can always take the questions at the end. Now, let's say my PT or APTT or fibrinogen are abnormal. What do I do next? Now, as definitely many of you knows, when PT or APTT are abnormal, the standard protocol is, okay, let's run a mixing study. All right, what is a mixing study really? A mixing study is done for a very simple reason. My PT or APTT are prolonged, all right? I want to know, is this a prolongation caused by a factor deficiency in the patient blood, or is it something else? So I have either a factor deficiency causing PT or APTT prolongation, and I have everything else. The everything else, I call them inhibitors. Very important though. When I say inhibitors, again, I am not talking about the natural inhibitors in your blood. And with natural inhibitors, I'm referring to protein C, protein S, and antithrombin. Again, PT, PTT cannot detect the presence of protein C, protein S, and antithrombin. When I say inhibitors in the context of mixing studies, I'm talking about things such as lupus, heparin, CRP, anti-factor antibodies, direct oral anticoagulants. These are not things which are normally present in your body. Yes, lupus are antibodies, but these are not normally present. These are pathological. Okay? So that's what I mean with inhibitors. I'm talking about things which are not normally part of your coagulation system. So again, mixing studies allows to differentiate factor deficiencies from inhibitors. That's fine. Now, one very important point, how do I interpret mixing studies? What is the normal range for mixing studies? Now, this is a very big topic. There are many ways to go about interpreting the mixing studies. I have added some very important notes. If you see there are notes attached to this slide, I will definitely share this with you at the end. So I would definitely recommend you to check particularly this slide because it shows you how do you work with mixing studies. It's very important. All right, how about fibrinogen? Fibrinogen is abnormal. What do I do with that? If fibrinogen is low, what do I do? Fibrinogen is high, what do I do? Usually there is no standard reflex protocol for fibrinogen. It's not that there is something like mixing studies for PT and APTT. What do I do next with fibrinogen depends on the context of the patient and depends on the value of the fibrinogen you get. So this is usually a clinical decision more than it is a decision made in the lab. Okay, so there is really no specific or standard protocol when your fibrinogen is low or high. As you can see, low or high fibrinogen does not trigger a standardized reflex testing like PT or APTT2. Okay, the rest is all right. Uh, See, as I mentioned, there can be mutations with fibrinogen. Now, investigating these mutations is usually not straightforward. The clinician sometimes needs to know, do you have a family history related to fibrinogen? So do you have anyone in your family with fibrinogen mutations? We need to run some specialized tests for you to know if you really have a mutation or it's just a matter of low quantities. So it's not exactly a very straightforward thing. It relies on your clinical presentation, etc., etc. So it's not something that really usually matters to application or to salespeople. It usually is a very clinical thing. Now, we run the mixing study. It says, okay, factor deficiency or inhibitors. What matters to me in this one? All right. Now, just a quick point about the mixing studies. What is their principle? When I say I have a factor deficiency in my patient blood, the factor deficiency causes prolongation because the clot did not form in time. What would happen if I give the patient the missing factors? This means their clotting time should go back to normal. This is very much the principle of the mixing study. You have a patient plasma that may be missing in factors. When I give this patient plasma the missing factors, it should go back to normal. So if my mixing study goes back to normal after I had a prolonged patient result for PT or PTT, this suggests that, oh, really the patient had a problem with missing factors. After I give them the missing factors, things went back to normal. So I say this patient had a factor deficiency. I assume you know that. All right, so what do I mix the patient plasma with? Where do I get the factors? I mix the patient plasma with something that I called pooled normal plasma. The pooled normal plasma has normal levels of factors. So when I mix it with my patient plasma, the missing factors are given from the pooled plasma. So now if really I have a problem with factors levels, the factors levels are restored by giving the pooled plasma. My mixing results should be back to normal. What if the mixing results do not go back to normal? Then this suggests the problem was not a factors problem from the beginning. It was everything else that I spoke to you about. Everything else, which we called inhibitors, coagulation inhibitors. Coagulation inhibitors are found by running a mixing study, and the mixing study does not go back to normal. We call this non-correction. Okay, so when your mixing study is non-corrected, you suspect an inhibitor. Now, how do I know what type of inhibitor is that? You cannot really know just by looking at the mixing study results. You just know that there's an inhibitor. But what is the type of inhibitor? You will not really know from the mixing study. You have to do further investigation. So when your mixing study is corrected, we say, okay, we have a problem with factors. You run factor assays to know what factor is missing. You will not know from the mixing study what factor is missing. Okay, mixing study is not corrected. What inhibitor it is? You will not know from the mixing study what inhibitor it is. You have to run further testing. So the mixing study just tells you factor is missing or inhibitor exists. Which factor is missing? We cannot know from the mixing study. Which inhibitor it is? We cannot know from the mixing study. It's not possible. You have to run further investigations. Okay, we know factors are missing. What do we do next? We run factor assays. What extrinsic, intrinsic, common? It depends. Is it PT that's a prolonged? APTT that's a prolonged? Both of them are prolonged? I assume all of you know the coagulation cascade. No need to discuss this point. How about inhibitors? What assays do I run? Now, this is a bit more, it's a little more complicated than the factors. Because again, inhibitors are many. We have CRP, we have lupus, we have heparin, we have direct oral anticoagulants, we have antifactor antibodies, we have sometimes some medications. Some types of antibiotics can cause prolongations. So, all right, what do we do next? Now, we have to start one step at a time usually. Next slide, okay. We spoke about this point. All right. Now, again, this is very important point. Remember that inhibitors do not refer to your natural to your natural coagulation factor inhibitors. All right, we're speaking about these guys, among others. So I think we finished this slide. All right. Now I have an inhibitor. What do I do next? Do I run lupus? Do I test for heparin? Do I test for TOAX? Do I test for CRP? What do I do next? Now, it would be important for you to know, first of all, that if the patient is taking heparin or DOAX, usually I can just ask the patient, do you take heparin? Heparin is given as an IV injection usually, or an IV drip. You would know if the patient is taking heparin because either the patient is in the hospital at that stage, or you can at least ask the nurses, is this patient taking heparin? If you have no idea, you cannot know, the nurses do not know, for whatever reason. Does the patient take heparin or no? Does the patient take DOAX or no? We can always run an antigen A test or a thrombin time test or Ikarin test to detect the presence of these anticoagulants. I want to know, does the patient have heparin in their blood? Yes or no? There is no heparin in the blood? Okay. There is no DOAC in the blood? Okay. So what else is causing the interference? Then we can check. Maybe the patient has lupus in their blood. Okay. I will run lupus assay. Does the patient have lupus? We found out, for example, the patient does not have lupus. So we excluded heparin, we excluded DOAX, we excluded lupus. What else? I can check, does the patient possibly have anti-factor antibodies? So it becomes a process of exclusion. We exclude the most common things first, then we go to the less common things. So for example, I will not immediately start testing for anti-factor antibodies when my mixing study is prolonged. Why? Because anti-factor antibodies are a very rare occurrence. Lupus is much more common than anti-factor antibodies. Having heparin is much more common than having anti-factor antibodies. Having CRP is much more common. So when I have an inhibitor, I don't test for everything. It becomes very costly for the lab and does not make sense. We start testing for one thing at a time. We can ask, for example, do you take heparin? Do you take DOAX? We can test for lupus, etc., etc., etc. So it's not something that's always just decided by the lab. The clinical context of the patient, okay, is very important. You can always ask the nursing team, what is the patient on? What do they take? Do they take any medication, etc., etc., etc. All right. So is there a specific protocol? What do we test first? What do you go with first? No, it depends on the context of the patient. But again, you never really start testing the thing that is least common. So you would not, for example, see a lab that says, whenever mixing is prolonged, we go anti-factor antibodies. That does not make any sense. Anti-factor antibodies are very rare. Usually I would start checking for heparin, DOAX, or maybe I start checking for lupus. All right. Now, small details about each of these inhibitors. Lupus usually is tested for in two occasions, either when the clinician directly requests for a lupus test because the patient might have clinical symptoms that suggest lupus, or if I have a prolongation that cannot, for example, be explained by heparin, we can go, for example, for lupus testing. Or it depends sometimes on the lab, what information they have. Now, CRP again. Sometimes CRP can be confused with lupus because it functions in a very similar way in terms of its effect on APTT. PTT automate is sensitive to CRP at levels of 85 milligrams per liter or higher. There's a study that was done on that, and you can see it. CQ-Prest, since again it's rich in phospholipids, is very poorly affected by CRP. So even if the patient has an infection, even a severe infection, CQ-Prest is likely to be normal, unless CRP is very, very, very high, but these are rare occasions usually. Heparins and DOACs, we spoke about this point. What are the tests that I can do for heparins and DOACs? There are actually multiple tests. You have antitin A, you have thrombin time, you have APTT, depending on the lab. You have eckarine chromogenic assay. But the point is, as long as we exclude these, we can look for other things because heparins and DOACs will interfere with everything else. They will interfere with your lupus, with anti-factor antibodies, and everything. That's why usually we exclude them first. Now, last of the things that we test for is anti-factor antibodies because they are the least common ones and they are usually complicated. Testing for anti-factor antibodies is not easy. All right. That's why unless I have a reason to suspect the patient has anti-factor antibodies, I do not test for these. Now, anti-factor antibodies are simply antibodies in your blood and the patient's blood, okay, which are targeting the coagulation factors. As you can imagine, an antibody targeting a coagulation factor means this coagulation factor can no longer do its job. Coagulation factor not doing its job means no coagulation. All right. Now, who might have possibly this kind of antibodies? Most commonly, they are patients with severe coagulation factor deficiencies. For example, factor 8, severe hemophilia A, severe factor 8 deficiency. These people, up to 30 or 40% of them, they end up actually with antibodies against the factor. So these people, no matter how much factor 8 you give them as transfusion, the antibodies will disable factor 8. So these people actually have to be given special medications. So, okay, then how do I quantify, how do I measure these anti-factor antibodies? We use something called Bethesda assay. So Bethesda assay is an assay that quantifies the level of the anti-factor antibody. All right, so whenever you hear Bethesda assay, we are simply trying to detect and quantify anti-factor antibodies. Bethesda assay can be done on all factors, factor 2, factor 5, factor 10. It's not specific for factor 8. Bethesda assay can be done on any factor. Okay, is there a protocol from Stago for Bethesda assay? Actually, Bethesda assay is mostly done manually. There's no analyzer that can do the Bethesda assay for you because it involves some preparation in tubes, some incubation for the samples in the water bath. So actually, on the analyzer, the Bethesda assay is just run on a simple factor assay. There is absolutely nothing that you need to set up on the analyzer for a Bethesda assay. Most of the work is done by the lab staff. They just do their work, then they run and see the factor level in the sample that they have it prepared. Then they do their calculations on paper. So there is no special assay for Bethesda on any analyzer. For example, the customer might say, oh, okay, but Sysmex, they have a special Bethesda assay. That does not exist because that has to be done manually. You have to prepare the dilutions manually, put them in water bath for a couple of hours, then you run the assay on the analyzer. So there is no special assay for Bethesda on the analyzer itself. That does not exist. It's just a normal factor assay. The customer does the rest of the work. We spoke about this point. All right. The important part here is now Bethesda assay is a very poorly standardized test. There's a lot of manual work. So if you compare your Bethesda results from your compact, for example, to a Sysmex CS or IL analyzer, the results will be very different. Actually, if you compare your results on your machine from this week results to last week results, there will be big variations. This is one of the main problems with Bethesda assay, and it's known, it's very well documented. So usually when the customer complains about discrepancies in Bethesda assay, there's really not much that you can do. You can just check, are they following the proper Bethesda protocol? If they are doing everything correctly, then unfortunately there is not that much that you can do with that. It's not a fault of the analyzer, it's not a fault of the reagent, it's just this assay is very poorly standardized and variation is very big, batch to batch, lab to lab. All right. Now, away from coagulation tests, we will go over some very important details related to D-dimer. Now, just a quick reminder. D-dimer is a product of fibrin clots. So when a clot forms in the body, fibrins are produced, fibrins grab into each other, they form a fibrin clot. Later on, the body no longer needs this fibrin clot. The body has repaired the tissue, repaired the damage, etc., etc. I need to break this fibrin clot. All right, I no longer need it. It starts to cause problems if it stays in your blood forever or in your tissue forever. So I have to break it after it's served its purpose. Now, after I break the fibrin clot, D-dimer forms. So whenever you see D-dimer in the blood, this is probably the most important part. Whenever you see D-dimer in the blood, this indicates that a clot has formed. Now, naturally in your blood, there is always a small amount of your D-dimer. Even if you are a healthy person, there's always tiny amounts of clots going on in your blood here and there. All right, this is completely normal, completely natural. Actually, you need that. If that does not happen, you will bleed. So there's always very tiny amounts of D-dimer in the blood. The problem is with high amounts of D-dimer because they indicate the presence of a major clot, which should not happen at all. Normally, unless, for example, there's surgery, there's a clot, stroke, something like that, then yes, D-dimer will be high to indicate that there was a clot. Because you cannot form D-dimer without a clot being present first. All right. Now, what is the value of D-dimer? Why do I need this test? What's the point of this test? The kit is too expensive. This kit takes a bit of a long time, and I can just run it, I can run PT-PTT. Why do I need D-dimer? You cannot really do what D-dimer does with PT-PTT. The value of D-dimer as a test is in its negativity. When D-dimer is negative, the only thing I can say is, my patient does not have PE, which is pulmonary embolism. My patient does not have DVT, which is deep vein thrombosis. There are two different types of clots that form in the body, and they can cause serious problems. PE can be fatal to actually 30 or 40% of the patients if not treated. Now, what about positive D-dimer? When I get a positive D-dimer value, usually the lab staff are freaked out. Why? What's the point? Positive D-dimer, again, indicates the presence of clot. Of course, a clot in the patient is a very significant event. The only problem with positive D-dimer results is that they don't tell you what kind of a clot is this. Where is the clot? So when D-dimer is positive, it can be clot, it can be a stroke, it can be infarction, it can be PE, it can be DVT, it can be, for example, trauma that is after a surgery. It can be for so many reasons. All right, so it doesn't tell you anything. When D-dimer is positive, it does not tell you anything. Its value really is in its negativity, because when it's negative, it can reliably exclude PE and DVT. But when it's positive, we really don't know what's going on. That's why we say it's non-specific to any particular disease or pathology. Now, the last line says, very high sensitivity and negative predictive value are critical here when talking about PE and DVT. Sensitivity means how good is your test at detecting the dimer? Is it present or is it not present? NPV is negative predictive value. How good is your test at saying that you don't have the disease? So sensitivity is how good your test at saying you don't have the dimer. Negative predictive value is how good your test at saying you don't have PE and DVT. So sensitivity has to do with the dimer itself. Negative predictive value has to do with the disease, PE and DVT. All right? Don't mix the two. Sensitivity is the thing that I'm measuring. Negative predictive value is the disease that I'm trying to look at. Now, very critical point. We said D-dimer is very good at excluding PE and DVT, but that is only for some patients, not for everyone. Now, when a patient, for example, walks into the emergency, they say, okay, I have tightness in my chest, etc., etc., etc. One of the things that an emergency doctor would do is they can run something called a pretest probability test or pretest probability screening. as you can see up here. Retest probability. The patient is suspected of having DEPE or DVT. All right. I will do something called the pretest probability. Pretest probability is I will look at your symptoms. I will look at you as a patient. Do you have a pain in your leg, for example? Do you have a pain here? Do you have this? Do you have that? Based on your answers, based on your symptoms, I can say you have a high probability of having a VTE or PE, in which case I will not wait for the dimer. I will immediately send you for imaging. Okay, because imaging can detect these things, can detect PE and DVT. Problem, it's way too expensive, it's invasive, so I cannot just run it for everyone. So if you have very high probability testing result, I will not even bother with the dimer. Immediately you go to imaging. However, if you have a moderate or low pretest probability, it's actually a paper with scoring, okay? That says this much is moderate, this much is low. So if you have a low to moderate pretest probability testing, that is when D-dimer is useful. So if your D-dimer is negative and you have low or moderate pretest probability, I say you have no VTE or no PE. Anything else, I cannot claim about my D-dimer. So again, the patient has to be low to moderate pretest probability testing. D-dimer has to be negative. At this point, I can exclude PE and DVT. Nothing else I can claim about D-dimer. One final very important point. This is only applicable to outpatients. Outpatients are patients who walk inside the hospital. I have a problem. It does not apply to inpatients. Inpatients are patients who are laying in the bed in the hospital for, say, a day or two or a week. Okay, so D-dimer does not really have much value for inpatients. Its value is for outpatients with low to moderate pretest probability. That's it. All right. Now, problems start when the lab use the dimer and start to compare their results to another lab or their results to another reagent. Now, usually, D-dimer tests, regardless of the manufacturer, they agree very, very well on the result being negative or positive. All right, so it's very good. It's very likely that Sysmex result, Stago result, IR result, whatever result, they will agree that the patient is actually negative. They don't have D-dimer. And they are very likely to agree that the patient does have D-dimer. However, the difference is the positive results, the high results, and the low results usually will be very different in terms of the value. So my D-dimer for Stago might say this patient has 3 microgram per liter. Sysmex might say 15 microgram per liter. The customer will freak out in this case. Which one is correct? How do I deal with my patient? Now, unfortunately, this is a very common problem with D-dimer. There is no fixing that. It's not a problem that you can fix. All right, then, what do I do with this? Now, first of all, what are the problems? What is causing this problem? The root causes are two. There are different antibodies used by different manufacturers to quantify the dimer. Your latest assay is an immunoassay. It's latex immunoassay, so it relies on antibodies to quantify the dimer. So every manufacturer uses a different antibody. This causes huge discrepancies in results. Again, the discrepancy is in the quantity, not in if the patient is negative or positive. Again, the difference in D-dimer results between manufacturers is in the quantity, not negative positive. Usually we agree on negative positive very well from manufacturer to manufacturer. All right, what's the other root cause is we use different standards to calibrate our assays. There is no international standard or international calibrator for D-dimer. So every manufacturer has to develop and calibrate their own assays and their own standards, which is another reason that causes discrepancies between these assays. So you have two very major differences, two very major root causes that can contribute to these differences. To give you a small example, the column to the left, these are different D-dimer assays from different manufacturers. We have 5 samples that you compared. Sample 1, sample 2, sample 3, sample 4, sample 5. If you look at these results, especially the ones highlighted in orange, look how different the results are from different manufacturers for the same sample. Some of them are even negative using some reagents and very high using the same different reagents from another manufacturer. So this gives you an idea that really different D-dimer reagents, they can have very, very big differences, especially in the numbers. For example, look at this assay. It goes from 485 to 9,210 nanogram per ml, which is a huge difference. 485 is negative. 9,210 is very, very positive. So, really this exists quite a lot. But again, remember, it's rare that you will see a discrepancy between negative and positive. So usually you will not see, Sysmex says negative, we see positive. These should be rare instances. They can happen and they can be expected to happen, but in very rare occasions. If the customer says your reagent is mostly negative, the competitor reagent is mostly positive, that's a very big red flag. It should not happen. All right, so the differences are mostly in numbers, in values, but not in negative positive. All right, then how do I decide on negative positive? What is negative positive in the context of D-dimer? In this case, the cutoff is determined by the manufacturer. The cutoff is, as you know, for example, for our assay, the cutoff is 0.5 microgram per ml. And I call it a cutoff because anything below the cutoff, I can say this is negative D-dimer. Anything above the cutoff, I can say this is positive D-dimer. So D-dimer below the cutoff, in our case, for example, means PE and DVT can be excluded. Remember, if it's an outpatient with low to moderate test pre-test probability test score. If the D-dimer is above the cutoff, we say a clot has formed. D-dimer is positive. What do you have? We cannot diagnose you. We have to do imaging. We can only diagnose the clot you have with imaging. D-dimer cannot diagnose the clot you have. D-dimer cannot tell you if it's PE or if it's DVT or if it's a stroke or if it's a myocardial infarction. It cannot tell you all of that. It just tells you there's a clot, go find it. If it's negative, it says there is no PE, there is no DVT. Okay, if D-dimer is negative, can I say you don't have a stroke? No, you cannot. Only PE and DVT. That's it. Now, finally, okay. The customer says, all right, Stago says you have this cutoff of 0.5 microgram. Fine, this is all good, but I am not convinced. I want to make my own cutoff. Now, establishing a cutoff for D-dimer is not an easy business. It's a very complicated work. It's a very big work. That's why CLSI says, okay, we understand this is a very big task. It's a very difficult task, very costly task. So CLSI says, if you want to use the manufacturer cutoff, this is completely fine. All right. If you want to verify it, feel free. Most labs, they do not have the resources to do that. So you can just take the manufacturer cutoff for D-dimer as it is, go with it. You are good. No problems. Just to give you an idea, for example, the cutoff for D-dimer for Stago, it was a study based on 25 different hospitals and clinics over 3 years with up to 4,000 patients. So that tells you how difficult this task is. And it's a very huge task. Good luck finding a lab that can do this kind of work. So you just use the cutoff of the manufacturer, whether it is Stago, Sysmex, whatever it is, okay? Who says that? CLSI says that. As you can see to the right, okay, this is from CLSI H59A. So you have the resources to support your claim to the customer, and you are good to go. There is no problem whatsoever. And actually, usually customers do not bother with the dimer verification. If they want to do that, they can do it. That usually is really insignificant, okay? If they don't want to do it, there is the document from CLSI that says this is okay, this is fine. And that's it. Thank you very much. If you have any questions or comments or anything to discuss, please feel free. So, anything, or we are all done? Yes, Mohammed.
Hello, everyone. Thank you, Leith, for this amazing presentation.
You are very welcome, my friend.
Thank you.
My pleasure.
I have a question related to BTT.
Yes.
I have a customer here asked about 2 points.
Mm-hmm.
Is there something called calibration frequency of BTT reagent or something called calibration due date for BTT test?
Okay. First of all, PTT is not calibrated at all. So that does not exist, yeah. No, it does not exist anywhere at all. It cannot exist because APTT is given second, right? and the analyzer directly measures second, without conversion into any other value. Even ratio is not another unit. Ratio is just second divided by second, so there's no calibration there. If I'm converting, for example, APTT into percent, such as what happens with factors, okay? Because, with factors, I run an APTT test, basically, okay? And I convert it into percent or IU per ml. In that case, you require calibration. But for your regular APTT, which you report in second or ratio, there is no calibration because you are not changing units. So that does not exist whatsoever, no.
Okay, thank you, Lee.
You're welcome. If anyone else has a question or a comment, please feel free. Otherwise, we can wrap up. Okay, so I assume it's all clear. Now, as usual, I will upload the recording and send it to all of you, and have a very good day, everyone.